So Brexu-cel currently is a CD19 CAR T-cell therapy which is approved for patients with relapsed refractory ALL, adults with relapsed refractory ALL with blast count more than 5%. We know from other studies that if you treat patients with low tumor burden, less than 5% blast, they may have a better safety profile and hopefully a better efficacy profile as well. So in this trial at MD Anderson, this is actually not a trial, this is a real world data, what we are treating as standard of care practice. We treated patients with very, very low tumor burden. So practically all the patients had less than 5% blast in the bone marrow. They cannot have any evidence of active leukemia in the CNS or an extramedullary disease. And those patients were assessed for NGS MRD by clonoSEQ assay in the bone marrow prior to lymphodepletion. And what we noted is that majority of the patients, we had about 37 patients, 25 of those patients where we had the assay available were actually 10 to the minus 6 NGS MRD negative going into the CAR T-cell therapy. There were 8 patients who were NGS MRD positive, and there were 4 patients where we did not have the NGS data. We gave them the CAR T. What we saw was that the toxicity profile was very, very favorable. We only saw 1 patient out of 37 patients with grade 3 or 4 ICANS, and only 2 patients out of 37 with grade 3 or 4 CRS, so very few high-risk toxicities. In terms of the efficacy, first we looked at the CAR expansion, and we saw that even for patients who were NGS MRD undetectable, there was CAR expansion, though it was less than patients who had more amount of disease present. In terms of the long-term PFS, this is the patients we're still trying to track them long-term to see how beneficial it is compared to continuing whatever therapy they were on as a maintenance strategy. I think that's a piece we are still long-term follow-up of the data. We did provide the survival curves in the abstract. So I think in the NGS MRD negative patients, we are seeing durable remissions for patients. There are some other patients who are relapsing. So I think that's a piece where I think we need to have maybe at least 6 or 12 months of more follow-up to make some conclusion whether this is an effective strategy for patients.